Dr. Prashant Bawankule is our next speaker. He's going to speak on 3D vitrectomy in ROP. And after that, we'll have Dr. Tariq Raza Ali, please. That's it. Sorry.
Shall I?
Please go ahead.
Yeah, thank you. Thank you. I'm really sorry to jump up the ladder, I should say, but I had to. One more commitment in the other hall. So friends, I would be speaking on my talk on, my talk is on basically 3D vitreous surgery for stage 4 ROP. Well, all of us know what is stage 4 ROP. Once there is a detachment because of the fibrous tissue contraction, if it is involving macula, it is stage 4B, and if it is not involving macula, it is 4A. And it happens typically at a PMA age of 41 weeks. Various options of treatment even in stage 4 is lasers. Lasers, if it is a few clock hours restricted, well, you just do the laser anterior as well as posterior to the ridge, and then you can get away in 1 or 2 clock hours. But in majority of the cases, you have to go inside. Scleral buckling was an option when the fibrous proliferation is predominantly anterior, but only if the traction exists anterior to the equator. But remember, this is an indirect way of relieving the traction which is exerting there. And that's the reason why it has only an anatomical success rate of 60 to 75% versus 50% functional success rate. Importantly, there is a myopic shift of -9 diopter, averaging -9 diopter, in spite of buccal removal, which needs a second procedure after about 5 to 6 months. So lens-sparing vitrectomy is the mainstay of the treatment with a success rate which is shown in 4A as to be 75 to 90% and in 4B 66%. Importantly, look at the functional success rate, which is 85 to 90%. And these are the advantages of lens-sparing vitrectomy when we do. Of course, the patient who receive pre-op anti-VEGF, but the pre-op anti-VEGF has to be given at the most 24 hours ahead of the surgery. And any patient who has received pre-op anti-VEGF and lasers tend to behave intraoperatively as well as post-operatively better. So what differently we do was, previously we used to look into the microscope and operate. Well, every one of us have been doing it for years, but now we look at the screen with the Polaroid glasses and operate. Is it only fashionable, or does it offer, even in this complex surgery, some more advantages compared to the microscope? Let us go see through this video presentation. Yes, it offers you a magnification, depth, field of view, illumination, and other advantages, which I would be running you through the thing. So magnification, this system offers is 24 to 40% more than what an analog microscope can offer you. And so look at this magnification at which I am doing an ROP surgery. This is unbelievable. You cannot think. This is a peripheral ridge which I am dissecting with the help of a cutter. Then I might do bimanual surgery. Here I'm pulling the membranes over the ridge, anterior ridge, which is just behind. And remember, let me remind you, this is in an eye which is as small, where 1/3 of the vitreous is already occupied by the lens. So this is a peripheral ridge where I am dissecting, and look at the magnification at which it is. And still, the field of view is as phenomenal, as big as you would love to have. Importantly, the magnification does not compromises on the field of view, but enhances the field of view. Now look at this particular case where you can see that there is a membrane which is attached at one place where I'm picking up, but they have tentacles attached in the periphery. While I'm pulling this membrane, the counter areas wherever the membranes are existing can be visualized simultaneously, and that is the beauty of having a larger field of view. Now look at the depth of the field, which is 11 to 42% better than an analog microscope, and this is important, and you will see through this video. Here there is a ridge. There is a membrane which is going from the ridge to the posterior surface of the lens. There is hardly any separation, but you can visualize how beautifully you can recognize the various planes, the depth, and you can comfortably visualize the depth of it, and you can have a very without creating any iatrogenic complication, you can do the surgery. This is just behind the lens. Look at the depth perception where you are getting. Yeah, you have certain advantages. You also have some disadvantages. In a digitalized image, the red color always gnaws, and therefore you need a filter which makes it more palatable. And all these videos which you will be seeing is at 1/10 of the illumination which you use in an analog microscope. So what are the aims of surgery? You don't have to do a complete vitrectomy. You don't have to induce PVD. You have to relieve these 4 traction points: ridge to ora, ridge to lens, or ridge to ridge, and ridge to disc to ridge. Disc to ridges, these are the only areas which need to be trimmed. So let us see what we do is ridge to ora. This is a connection where we just trim it. This I have already shown you. Ridge to lens I have shown you. Now this is ridge to ridge, which is more of a circumferential type of attraction where you are using a cutter. Look at the phenomenal depth and field which you are, and this is disc to ridge, which has to be relieved. Now let us see through this complete videos. This is few clock hours of traction in a post laser stage 4 ROP. After having done basic core vitrectomy, here I'm cutting off this is now circumferential traction, that is ridge to ridge connection. And just once you relieve these traction points, you have to add some laser to the areas which were skip areas during the primary laser procedure, and then do a fluid air exchange, and that's it. Now this is another video where you can see the fibrovascular proliferation. You have to be really early entering into such eyes. You do not need to wait for the retina to really get more taut and more be pulled up into the vitreous cavity. And if you intervene early, you can have definitely better results. You have to be very careful. This membranes sometimes are difficult to discern from the adjacent immature retina, and it's only a matter of practice that you learn when not to do it. Now this is another case where you have more severe proliferation in the anterior part of the vitreous. I will just run through these last 2 videos. And once you relieve these tractions, you have to take care of the hemostasis with the help of a minimal cautery. Cautery cannot be very aggressive, otherwise it can lead to further breaks. And once a break in a case of a ROP, the case is almost doomed. Rarely do you need to sacrifice lens, and the only indication is when you have a proliferation anterior to the equator, I should say, that you have a very anterior. So this is the lensectomy which is being done, and after lensectomy, look at the magnification. You are seeing the ciliary processes, and I am doing dissection at the ora, almost the ora. And the magnification and the depth which you can pursue this is the advantage of this particular system. Dr. Dogra sir has proposed this nasal sitting for temporal tractions, and here is what I am doing through this video. Okay. So to summarize, minimally invasive surgery, that is lens sparing vitrectomy, is definite way of tackling a stage 4 ROP. Pre-op lasers and anti-VEGFs improve the success rate. Remember, total vitrectomy, neither PVD is the goal of the surgery. Relief of only 4 tractions, that is ridge to ridge, ora, and lens to disc, is important. And 3D digitally surgery eases this complex procedure by a unique combination where you see in a very magnified view, a big field of view, and allows you a great depth. So thank you, friends. This is just a tribute to all the patients who trusted, small babies who trusted their eyes with us. Thank you once more.
Thanks, doctor, for your excellent presentation. Just one question only I have. Do you suture the sclerotomies in these patients?
Of course.
Great. Thanks, doctor. Thanks. So next I'll be inviting our invited faculty, Dr. Tariq Raza Ali. He'll be again speaking to us on diabetic membrane shaving. Please, doctor.
Good afternoon and greetings from Dhaka. Really, I'm very much honored to be here, and I thank our organizers for inviting me. It is not very easy to talk in front of my mentor, Dr. Ajit Babu is here. Anyway, he is a great diabetic membrane shaving surgeon, so I'm talking in front of you that diabetic membrane shaving simple and safe. Please start the video. Run. As you know that here after the core vitrectomy, so a lot of cases we have already seen this high-speed multi-purpose advanced cutter has made our membrane removal very simpler and safer. You have to do the core vitrectomy, remove the anterior and posterior tractions, and then find the gap between where you can enter and remove all the membranes. This requirement is to create this potential space between the membrane and the retina. It is not always easy, but here in all my cases, I didn't use any any forceps or any scissors. I just cut with the cutter, and it acted very nicely. Just only you have to go through the perfect plane, and shaving is done using the low vacuum but high-speed vitrectomy in shaving mode. That is very important, and you can remove all the membranes as you can see. Here, this is separate new case. You see, you can trim and you can cut in between. And in some cases, you need the back cutting. You see, back cutting is at maximum cutting speeds. The probe is faced anteriorly, and you can cut the membrane. You can use your suction only to remove the membrane and cut in all the cases. This back cutting is very important for shaving these membranes. Another thing is if there is no potential space, you have to cut the vitreous in such a way that inside out dissection is done from the vitreous, that is from the optic nerve, and from center to periphery, you have to do the fibrovascular tissue cutting. So these are all the techniques you are using, everybody is using in our cases, but very cautiously to find the gap in between the retina and the membrane. This is the most important, and very slowly and very carefully you have to dissect so that there is no iatrogenic break. This inside-out dissection done detaching the fibrovascular tissue from the optic nerve from the center to the periphery. This is important in some cases if there is no potential space. This is another case. You can see that we have used a suction and then cutter and remove the membrane slowly in separate cases. This is another case, very adhesion, and you can remove the adhesion with a suction and then find the plane and the cut with your cutter. So these are the cases in day-to-day we are facing in our diabetic patients, and here are so many diabetic membrane shaving patients. That is, presentations are here. It shows that everybody we are facing this type of patients, and in our day-to-day practice. So diabetic presentations are much more also. So just remove the membrane. You see, this is one. Cutter. Before cutting, you have to use the forceps. In this case, I used. Then, after the plane, I use the cutter only. Sometimes you can find this type of fibrous sheet over the retina, and with the back cutting procedure, you can remove all the membranes slowly and slowly. This is done. This is a very cicatricial case, and again we have done this way, this back cutting technique to remove the membrane.